So this is in case you're not able to intubate a patient, or you're not comfortable intubating a patient, or it's a difficult intubation. That's when you use our supraglottic devices. Okay, we have our LMAs, laryngeal mask airway, and we have our eye gels. Okay, they're a bit different. These have cuffs, as you can see. These have gel. The gel has run out, but they have gel, so when you put it, they swell. When I say supraglottic devices, what do I mean by that? Where do we go? Just above the epiglottis. Remember, when you're intubating, you're going through the epiglottis, yeah, into the airway, yeah? You lift up the epiglottis and then you go through the vocal cords into the airway, right? These ones, you sit above, okay? That's why they're called supraglottic devices. Okay, above the glottis. Okay, they're also known as rescue devices. Okay, they really help a lot of people. For those who are not comfortable intubating, sometimes this really helps you. You're not able to intubate. Okay, so these are the two main ones that we usually use. They have different groups. I mean, they're different LMAs. They're different types of eye gels. Okay, but I'm just gonna do the basic for you. These are the common ones that you're going to see around. And these ones, LMAs, eye gels. How do we size them? Imagine it's so easy. They come in kilos. Is that fine? So there's no need to figure out, or you wonder if I'm doing magic by saying number 1, number 2, number 3, number 4, number 5. That's how they come. Okay? So 1, 1.5, 2, 2.5, 3, 4, 5. Okay? That's how they come with the kilos. As they are written here, 10 to 25 kgs, 30 to 60 kgs. Okay? Then you'll see 50 to 90. Okay? Above 90. Right? Yeah? Same with these two. But usually this, it's not written here for some of them, but this one is actually written 30 to 50. Sometimes you see them on the box itself. Okay? You want to see this one, does it have it? 10 to 20. Okay? So that's how you know the sizes and what to ask for. So you ask the kilos of the patient prior. Sometimes if you have to estimate, you can estimate. As I said, sometimes it's always good, the same way that you get our endotracheal tubes, have two sizes. Okay? Start with the smaller size. You can see, if I'm going to look at him, I may start with a size 4 tube, eye gel, but I'll have a size 5 close by. Because maybe I don't want to, because we already crossed paths badly. But, not really. But, he may be 85 kilos, yeah, and then size 4 takes up to 90 kilos. But he's on a 85, I can do a size 5, that the size 4 is I'm not able to ventilate the patient. Okay? That's okay. Yeah? Do you want to look around? But anyway, you're all going to touch them when you come here in the front. Yeah? So how do we approach a patient? Generally, an airway patient. I know some of you are here for the basic airway part. These are patients who have a pulse. Okay? So we're not resuscitating. We're not going to check for pulse because you're so many and you all have to do the skill. Okay, so this is a patient who just has no airway, but they have a pulse. So we're not resuscitating. Approach the patient. Mr. X, are they responding? They're not responding. The next thing is you're going to look, listen and feel, yeah? What are you looking for? Maybe there's something in the mouth, yeah? Okay? And then you're going to listen, because you can hear breathing, right? Now, if you're not hearing because you're in a noisy place, you'll feel that moist on your cheek, okay? So look, listen, and feel. If you're not feeling that, the next thing that you're going to do is head tilt, chin lift, open up the airway. Now, I said when you're at the airway, you're like a boss, you're always at the top front of the patient. Please never look at the airway from these sides because you're not gonna see. Come to the front of the patient and look inside. Look inside. If there's something that you can pick up, please pick it up. Okay, then if it's like he's gagged, he had some lunch, his food has come up, suction. Okay, suction. Two things you're going to do, remove the stuff out. Other thing you're going to check is for a gag reflex. Right? Then you can go in with your OPA. I'm just going to the first part of things. Measure your OPA, angle of the mouth to angle of the mandible, slide it in. As I said, we used to do this before. And then twist. We don't do that anymore. She gave me a good idea. You can use a tongue depressor, put it in. Avoid the twisting because of scratching the upper part of the palate. Okay? So put in your OPA. right? Then bag your patient. Yeah? CE, bag the patient. Okay? So that is usually done. And then now you're going to either try and intubate. It's your first day in the ED or your second day in the ED. You do not know how to intubate, or you're scared to intubate. Or your cadre, they say you can't intubate in that hospital, get an anesthesiologist to intubate. I mean, there are different reasons why you cannot intubate. Then you ask for your iGel. Before all these things, before you go putting in this, you should be able to first ventilate your patient. Okay? That's fine. Yeah? So then, this, when you open it, it comes in a pack, you open it up, it's usually sticky a bit here. Yeah? So you don't need to lubricate again with KY jelly. But for here, because this has been used multiple of times, I'll lubricate it for you, just for it to go through the dummy. Okay? It's a spoon. How do you want to put it? Have you all seen how I'm putting it? Yeah? The hole is here. So this is where the air is going to come out from. So don't put it like this. This has to go. Okay? So you just slide it. You can use even a laryngoscope, or you can use a tongue depressor and just slide it. This is plastic on plastic, so it's a bit harder, but it should slide in. It's hard, yeah, because it's plastic on plastic, so it needs a lot of jelly inside. But trust me, it's not as hard on a real patient. It's so much easier. There, it's about the same. I think I need a bigger one. No, it's hard. It's not a. it's literally plastic on plastic. So it's in, okay? So how do you know that it's in? Huh? You can bag the patient, or yes, we can bag the patient. Use a what, sorry? You connect to a waveform capnography. Something else before you start attaching all these things, it's better. Where is it not plugged in? Hey? It's not going in. Oh, they have the bigger one. Imetoka. Long imetoka. Hey. You guys are laughing. You're the ones who have broken my mannequin. You're laughing. Come here. It's a hot seat. Ask Dorothy. Okay? So, how do you know that it's in? One, okay, with experience, when you put in, you feel like a click. Because you reach the end. Okay? So when you put it, you feel like it's set. So yeah, it's not like a broken bone, but it's set into its place. Okay? Secondly, bag the patient. Equal chest rise, attached to a capnogram. Okay? See our capnography waveform for those who have it. And then auscultate your patient. 5-point auscultation for us to know where it is. Please strap your airway. You can still go even on the ventilator with this if you want, till you're able to secure a proper airway. Okay? Yeah, but you have to strap it. Other thing that you also add is your HME filter whenever you put in any airway devices, or even if you're using a bag mask. There's a lot of disease. We just came out of COVID. Please ensure you have a HME filter. Is that okay? So from here, you'll take your tubings. If you're going on the ventilator, attach to the ventilator. Strap the LMA. iGel, this is the iGel. Okay? So that's iGel. There's no inflation, there's nothing. You just slide it in. Now let's go to LMA. I should let you do this one.
So the main difference between the LMA and the iGel is that this one comes with another opening here that allows you to sort of suction the esophagus, is where you drug the esophagus. So this has this, which you don't have in that. This is the first generation element here. So that's the main difference. Second generation, and it allows you to do that, okay? But they are both for the same reason. Again, hold it as a pencil. I'm copying words from my professor. Hold it as a pencil. The direction that you want it to go. Airways. Yeah. Slide it in. Again, dummy, so.
You have to deflate. Deflate it.
It's deflated. Also.
Yeah, you really have to push it.
Or you use whatever. Let's use that. Let's push it.
You can push it in.
Itasumbua watu.
Just the feel. Ingia. It's not sliding down. There's a place it triggers. Let's see.
Only the other one is harder, so it's easy. Don't think you remember.
It's there. You've seen?
So, as you said, it's a little bit easier in a light patient. So, again, follow the steps. Make sure that you're ventilating your patient well. You want to see chest rise, right? If you have a capnography, you can connect it here, and it can tell you you're actually ventilating your patient, and then you can also auscultate your patient. This one has cuff, so you have to inflate your cuff, okay? So after you can now inflate your cuff. And again, secure your airway. You can continue bagging your patient to those of us who are in transport medicine and ED as you wait for your next step, or as you wait for someone who can come and maybe do an advanced airway intubation if you can do an intubation yourself. All right, yeah. So more advanced ones, some of them come with an extra port that you can use to actually slide in your ETT, all right? Yeah, but we don't have that, and we're not going to get into that today, all right? Okay.
Okay. So now we're going to go to the practical part of it. The main thing I just want to see is inserting one of them, either the igel or the LMA, whichever you're comfortable with, and then bagging the patient, okay? Yeah, so the whole part of the first part that I did, you don't need to do that because you're quite a group, but just for you to get the feeling of how to put in an igel or an LMA is what we need, okay? That's okay? Who's ready to start? You? Come. So which one do you want? This one. Okay. So sorry, one other thing, when you're deflating this, put this on a flat surface to deflate. It's usually a bit easier. Okay? Can see? To deflate it so you can insert it. We put so much of jelly, don't worry. No, I've put, it's a lot of jelly. You should be able to deal with that. It's about technique, guys, eh? So strength. Yeah, now that's muscle. Yeah, it's not it's technique plus muscle. Imefika. This one is not going to go so deep. It's not going to go so deep here. Okay, one is inflating. Yeah, both are inflating. This one can't go both. You can't go so deep here. They're both inflating. Okay, next. What do you want, the IGEL or the LMA? Let's interchange. Yeah.
Let's try the LMA and use the IG.
Yes. People are laughing at me. It gets to a point now, just push. There. Yeah, it bends. That just. Yeah, this one has to go deeper.
Perfect.
Yeah? Okay, next.
Yeah.
All of us have to do. So, so now let's move from this side. So I know everybody has done. So one this side, one this side, one this side, one this side, okay? So two other things. These are non-trauma patients. Please don't do this when you have a trauma patient. The seat's fine, okay? No, it's okay. This is a non-trauma patient, okay? This is a non-trauma patient, just to make it comfortable for you. It's a non-trauma patient. And don't do this if it's a trauma patient because of the C-spine. Okay, you're not cleared C-spine. So use your hand. Remember, we have gloves. You want some gloves? I can give you some. You have tissue to wipe. It's just jelly. Remember that. Yeah, don't push it too far. This one is a big one. Yeah, it's working. Okay? Next. What do you want? Let me give you the IGEL. Yeah. You literally just push it in. Okay? Even on on a patient. It's so easy. It just slides, by the way. Yeah? So I tell you, wait for someone to come and help you intubate, you've already able to, yeah. Okay. It's about to take strength a bit there. Yeah, it's in. Wow. Next, from this other side. It just gets to a point, so it can't go. There, have it out? Yeah, there. So, the same way we are adjusting these things, you also adjust them sometimes in a patient. Next. Where is it big? It's slow. What do you mean slow? No, because I had to pull it out. It had not reached where it was meant to be. So I said slide it down the mouth. When you hear it stops, then attempt bagging for the patient. Next, from this other side. If you have any questions, please ask, because by the time we get to all of you, we may not have time to answer questions. Actually? Sana. Good job. Next, from this other side. If there are any questions, please ask. Any clarifications also? Maybe I need to ask you, when did you use a supraglottic device? When can't you not use a supraglottic device? Huh? When you can, not when you can. When can't you not use a rescue device? Contraindications. No, I asked it before you. I asked it before because I asked, do you guys have any questions? People said there are no questions. So when is a supraglottic device contraindicated? Pull it up a bit. There. Huh? Hey, now one by one, guys. You have to put it. Yeah, you have to put it in the center. Sawa. Next. When is a supraglottic device contraindicated? Obstruction with what? Remember, when you're going to open the mouth, you have to clear the airway. With what? But you should remove the foreign body. It's not visible. Yeah? But if it's not visible, how will you put even a tube? Huh? So if you have an obstruction, I'm not refusing, yes, you can have an obstruction, but you can't see it, meaning it's gone through the airway, right? There. So. Okay, someone has said what? Vomiting. Okay? A conscious patient, you should not be you should not be putting an airway. You should be taking them for tea if you want. So if you have vomiting, okay, right? You don't put in a LMA or a igel. Say put a secure airway. Why? Aspiration. Then remember, this is just above, so you're also filling the stomach with air. Okay? So you'll end up. Something else? Something else? Something else? Anyone? Next person?
When you have maybe trauma to the trachea.
So you have trauma to the trachea? How? How are you going to see trauma to the trachea? How are you going to see trauma to the trachea? Stab wounds to the neck? Good. Yeah. Something else that commonly happens. I'm looking for common things. Common things commonly happen. A what injury? It can still be your life savior. It can still be your life saver.
That one is for the
This one.
that's when the
Something else? Tumor where? Good. Next, tumor where? Tumor in the upper airway. This can be your lifesaver. You know that. You can't intubate. This can be your savior. This is your rate limiting step between this and lunch. So, something else? Good. It's good. Foreign body, but you should remove the foreign body if you're seeing it. That's why we do look, listen, and feel. The one that you can't remove, obviously, is anything past the epiglottis. Yeah. But anything else in the mouth, you should be able to remove. Something else, guys. Active? From where? From GI bleeding. Yeah, that's one also. Something else? Something that you guys, it happens every cold season in Nairobi. If you work in a hospital, it's the most dreaded call that you always get if you work at night. What happens when it's cold? What happens when it's cold? You people. You're going to put LMAs in asthmatics. You're going to ventilate. You're going to nebulate. Yes, I didn't finish what I was going to say, Rukia. What happens? Okay, stop thinking about suburbia. Okay, let's think about lower end Nairobi. Okay, what happens commonly when it's cold? What do people do? They use what? What do they use in? They use what? In their houses. What happens? No. What happens for carbon monoxide poisoning? You don't even get to carbon monoxide poisoning. Burns happen. Inhalational burns. Are you going to put a eye gel? Or why do you put a tube in burns? What happens? Edema where? Laryngeal edema. So are you going to put a LMA? Stress that airway and then you'll really shut it, okay? So if you have patients who have burns, avoid. Unless you're really stuck, as you're waiting for somebody to come. But it's not something you're going to leave the patient with, to ventilate the whole night with, right?
Yes.
Something else?
And anything that causes, like if you have anaphylaxis, and you know, anything that will cause.
Just enter.
It's very difficult.
It's hard. It's okay, just hold it there. This one doesn't go all the way. Mm-hmm. You're not in the center. Move to the center. Starting, kidogo. It out. Yeah. You've seen? So. Yes.
You said we don't tube.
No, I said don't use these things for a long time because you need to protect the airway. That's why we even intubate them. Yeah. So if you're able to intubate, what do you want? You get a choice. This one.
What about pregnant patients?
What? Pregnancy? You can use it, then you go for a definitive airway after that. Second trimester is okay, the fundus is not so big. Third trimester is where the issue is because the fundus is pushing up. That's okay. Next. Are we all done? I don't think so. Mkaribie wale hawajafanya. So, are you guys comfortable putting this in your place of work now? Yeah? Are you comfortable? Yes. You'll be able to put it? Okay. It's okay. Just leave it like that. Yeah. No, that one doesn't go. So remember what I'm noticing about, anyway, I'll do it as a recap, but there's something all of you are doing when you're coming here.
Not yet.
Yeah. Next. There, plastic on plastic. But it worked. Next. How many people are left?
Maybe to echo what
So come on this side.
colleagues are saying, maybe someone else didn't get it clear. The only difference between a trauma patient is you don't do head tilt, chin lift. Huh? What we are trying to communicate is in those patients you do
You guys have done.
a jaws first.
Have you done?
Head tilt, chin lift,
Come on
but
this
that doesn't mean that you can put it.
You guys have done.
Place an LA.
Msonge yuko chini now. So these guys can get space to come.
Most of the time, your indications for your LMA will be probably pre-transport if you can't intubate and you need to take that patient, right? Or if you have the LMA that helps you to intubate, as I mentioned, the LMA that comes in with a pot, so you're using it as a measure to try and help you tube your patient. And then in your difficult airway guidelines, it's part of your management. So most of the time, those are the three instances you probably need to use an LMA.
Swali, kama hauna experience ya kusikia click, like what length do you go?
How do you? Sorry?
So the reason why it was made in the first place was to make it easy so that anybody can use it. So you just push until you feel resistance.
Yeah.
Ideally, if you're using the right size for the right patient, it will just go and fit nicely. So you push until you have that resistance. But if you can't bag, you can try and adjust it a bit. But unaskuma tu.
Yeah. It's not an ETT tube that we have to measure because we're not going anywhere. We're just above. Good.
Sure, most people have.
Basi mbona iko na markings za length?
Pardon?
Why does it have markings?
So it's the length of the tube, but it's not where you're going to tie it.
No, but now if it doesn't have relevance, then why?
Which ones?
I feel like the high gel goes
Easier. Because it doesn't go all the way. This one bounces. This one doesn't go all the way. You can't put it all the way. So it's the wrong length for this patient. It's too deep there. The more I pull it out, the better it
to
is.
get the concept.
Okay.
The idea is to get
How to do it. And please never pull it out when it's not deflated. You'll traumatize your patient more. Can I have this? Use this one. Good. Next, you want to use the same one? It's just okay. There's no award, don't worry. There's no present. There's no extra lunch you're going to get. Because that's not the right size for it, but it should go in as easily as. So then I'm almost done. Yeah. Wait. Deflate, yeah. Next. Actually, I'll stop using this one now. It's even dried. It's dried.
For the patient who you suspect a C-spine, are you going to put a neck?
What?
The patient
The suspector?
For the patient who you suspect a
C-spine.
C-spine.
You still put
Do
it,
you
but
put a neck or a pulse, or do you put a neck?
so all those things usually happen at the same time.
Yes.
Yeah. So you can put the collar as you're holding and ventilating, because the main thing, you're able to ventilate the patient. Then these airways can come in afterwards. Yeah, but if you're not able to, then you can still put in the airway, but you have to support it. You want me to back for you? Oh. Next, yes.
What are you saying that we're all doing wrong?
I will tell you. You're almost done, isn't it? So just that you left. And Christine. Hey, Christine, how are you? Yes. I'm tired. Good. You see? It's dried. It's dried. That one has dried up. It's sticky. It's working. Your left? Yeah. Oh, finally. Yeah. She's the last one. Everybody else has done?
Any questions? Any comments?
Oh, good. So I think everybody has attempted an iGel or a LMA, right? I said it's so much easier on a patient because it's soft tissue with plastic, so it slides, swells, and just sits there. And the other one, don't forget, you have to inflate. LMA, you always have to inflate the cuff, okay? iGel, you don't need to. Don't put too much of jelly. Already it's gelled properly because you pick it out of the packet and then put it in, okay? So one thing that all of you people were doing were, one, you're not on the midline. So your tube is here, here, everywhere, okay? So let's just try from the center, go in, okay? Yeah, as I said, it's always easier on a patient than on the dummy, okay? So be on the midline as you're ventilating, and then ensure they have bilateral chest rise for both of them, not one side. It's a bit hard to have one side, but try to be on the midline, then on left or right side, okay? Ensure you also secure your tubes. Yeah, once you're settled and comfortable with it, secure the tube, and then go on. If you're bagging or in a transport ventilator, then you can attach it to it. The other thing, C-spine patients, I was being asked a question, are you going to secure the C-spine or are you going to go for the airway first? Remember, when you approach a patient, it's different things at the same time. I'm not like, wait, do this, wait, do that, okay? So I said all these are rescue devices, they assist you, but the biggest thing is, are you able to bag mask your patient, okay? So as I'm holding down, don't do a chin lift, head tilt, hold down, jaw thrust, bag that patient as they are trying to secure the C-spine. And you're not bagging one breath in 60 seconds. Remember, you're doing one every 6 seconds. So you'll have to stop for them to tie the C collar and then continue your bagging from there. Okay? Yeah?
When you check at the trauma management pathway, we talk about now the CADC. If you're suspecting, of course, all trauma patients are suspected to be having a C-spine injury until
Yes.
so you do your C.
To clear your C-spine.
Yeah, you clear your C-spine and then you do your ABC.
Exactly. But when you approach a trauma patient, you can see we don't say, okay, here is patient X. let's Esther clear C-spine. And then Akil, when she's cleared C-spine, come to deal with breathing. And then another person deal with... Is that to... Yes. But you know the first person is check clearing the C-spine as you're wearing your bag mask, as you're listening for breathing. She's not the same person who's doing C-spine, not the same person doing breathing. There's still circulation, airway, IV access that's needed, and airway to be secured. It's teamwork. You're never alone in these things, okay? But there's one person who is your team leader and guides all of you people to it, okay? So you're not fighting. There's an order to things. Okay, C-spine cleared, C-spine not cleared. Let's get a collar. Okay, you who's bagging, stop, tie the collar, or put headboards, okay? Yeah?
If you're the first person approaching the patient, you will be the airway person, right?
Yeah.
So you come, do your first, and you will not leave this place until that.
Until someone else comes to help you, yeah.
So you always go approach us too, eh?
Yeah.
So the person who come number one, you're the one to open. Because remember basic things first. You need to know if you can ventilate your patient before you put all these things. So if you're just saying, it's up to you. Are we responsive? No. Airway, okay. Open the airway, we are doing a just in this case. I'm the same person who can open and check. If you have a tooth, if you have secretions, then you call me. You need suctioning. Someone else now comes and suction. The person who's suctioning is probably going to be the person who's going to push them. Whatever you need, the OPA or the LMA, as you prepare to stabilize the spine. Okay? Because everything that you need to do for that patient, this person needs to stabilize that spine until you get a proper C-spine collar.
Another question, Doctor.
Yes?
There's controversy. According to EMKF, they're basically discouraging the use of C-collar.
Yeah.
I don't know what is the idea there.
Headboards.
Are we still using C-collar? We just use the head blocks.
Head blocks are the best.
Why not C-collar?
Because there's a lot of manipulation.
Exactly.
With the C-collar. You can move. With a C-collar, you can your head. Remember that. It's not that tight. The soles, the movement. But if I strap you with a head block, you're not going to move because you're strapped down. Yeah, and that's what you don't want.
I remember in your trauma patient, you're not only querying you have a C-spine injury, it's actually a full spine injury. So in any situation, those of us who do some hospital things, any trauma patient you approach, you should assume that patient has a spinal injury until proven otherwise. That means full board, okay? Like full spine immobilization. So if you have a board, then it's easy to put the patient on the board and put the blocks without manipulating the C-spine, right? Yeah. But if you're in a very resource-limited area and the C-spine is the only way to stabilize that patient, if you have to transport them, then you can still use it. But the person who's doing it has to be really experienced, right, to do the inline mobilization and stuff. So if you're not comfortable with it, don't go trying to put the C-collar in.
The blocks. Yeah.
If you have orthopedics guys, there are some of them actually really well trained to do that.
There's another question? Yes? Or is the same question? No. Any other question? Any other clarification with supraglottic devices? We've talked about what you commonly come across in your places. I said there are so many supraglottic devices, so many different types, but we try to keep it to what you know and what you're going to find in your EDs, because there's no need for me to teach you on something and then you'll never find it. Yeah. So what you'll see and what you'll find are those usually the LMA and the IGL. The straightforward ones, not the intubating or the ones that you can put an NGT tube through. And they have anchors. Sawa.